We will start Symposium of Roche. The speaker, Dr. Nawal Tuhami, my dear professor. Her topic will be role of immunotherapy, monotherapy in metastatic non-small cell lung cancer. Please, Dr. Nawal.
ملحقتش اقعد معاه.
ان شاء الله ان شاء الله.
بسم الله الرحمن الرحيم. ثانكس دكتور هشام. ويسعدني ويشرفني ان انا اكون في بيتي جامعة عين شمس قسم الاورام. استنى شويه.
Please, I ask the floor to sit down, please. We'll start the symposium.
مش عارفه اقول ايه صراحه، يعني وحضراتكم قاعدين وانا هتكلم ازاي؟ يعني it's so difficult. الله يكرم. والله يسعدني ويشرفني ان انا اكون في بيتي قسم الاورام جامعه عين شمس اللي علمني الف ب اورام والف ب طبعا نون سمول سيل لان كانسر دكتوره ايمان. This is my disclosure. And I think that non-small cell lung cancer as a disease is a very good example for what is occurred in the oncology or cancer treatment in the last decades. As we are starting to treat patients as one drug fit all, at the beginning with radiotherapy for all of the patients, then chemotherapy for all, and moving now to treatment for each patient based on the molecular profiling. And what is the factors that affect our decision of treatment in first-line non-small cell lung cancer metastatic type? There is factors related to the disease itself and factors related to the patients. To the disease, histology is a very important factor as it affects the choice of chemotherapy. We have protocols for the squamous and protocols for the non-squamous. For non-squamous, we have pemetrexed and bevacizumab that cannot be given for the squamous histology. And also, it's very important to test the targetable mutation first before starting treatment, as we have many mutations that can be targeted by TKIs that can affect the progression-free survival and also recently the overall survival. And regarding the immunotherapy, the test of the PD-L1, until now we don't have except PD-L1 for deciding which chemotherapy or immunotherapy to be given. And also the patient factor is very important, the performance of the patient, the goal of treatment, and also to exclude any autoimmune diseases if we are going to give immune checkpoints inhibitors. The IO biomarker in this field, there is only PD-L1 test that has an evident, and based on the result we can move for single immuno or combo test. We have some promising data for the tumor mutation burden, but until now, this is a gap that need more further investigation for more personalized treatment. PD-L1 testing is not a single test for all of the drug and all of the disease. For example, for pembrolizumab in lung, we test the PD-L1 by TPS score. For the other malignancies like head and neck, gastric, or gynae, we test by CBS score. So it's very important to mention the disease type when we prescribe the PD-L1 test. And for atezolizumab in early lung is different from the metastatic. For the metastatic PD-L1 test for atezolizumab, we use the tumor cell and the immune cell, a combined of both percentage of PD-L1 positive. And for the adjuvant, we use the tumor score only. This is the PD-L1 expression by the TPS score for pembrolizumab and similimab. TPS score is scored less than 1%, and what we are calling a negative PD-L1. Those with 1 to 49%, and those with high expressors more than 50%. This is the PD-L1 by the DACO test. And we have, this is for Ventana, for atezolizumab. The score are based on the PD-L1 expression in tumor cell and immune cell. For more than 50% in tumor cell, we call it TC3. And for immune cell, it must be more than 10% to score it as a high expressors in immune cell, IC3. And the approval for monotherapy in the non-small cell lung cancer is not started as a monotherapy in first line. Actually, it started in the second line by the 3 drugs, pembrolizumab, nivolumab, and atezolizumab. It was approved as a single agent first, as a second line treatment after progression on chemotherapy. And the patient showed improvement in progression-free survival and overall survival for using them in the second line. Nivolumab and atezolizumab must be tested, are given regardless of the PD-L1 expression, but pembrolizumab in the second line must have a TPS score of 1% or more. At least we have to give it in positive PD-L1 test. And after that, many trials are incorporating immune checkpoints inhibitor in first-line treatment, either monotherapy, started with pembrolizumab, and the combo for chemotherapy plus immuno. This is our focus today, the monotherapy immune checkpoints inhibitor as a first line. Actually, we have 6 trials. 2 of them was negative, the checkmate 026 for nivolumab and the mystic durvalumab monotherapy. And both of them, unfortunately, was negative trial. So nivolumab or durvalumab as a first line monotherapy in high expressors is not indicated. Then we have 4 positive trial, Keynote 25 and Keynote 42 for pembrolizumab. And we have Empower 110 for atezolizumab and Empower Lung 1 for cemiplimab. Let's start with the first one, checkmate 26. It was including patient for with advanced stage 4 non-small cell lung cancer with no targetable mutation and with positive PD-L1 expression, nivolumab versus chemotherapy, and the result showed no improvement in progression-free survival or overall survival in patients with PD-L1 more than 5%. Then the MYSTIC trial, also the same design, but irrespective of PD-L1 expression, durvalumab versus chemotherapy. And again, despite we have a numerical difference in overall survival, durvalumab didn't show a statistically significant improvement in survival in patients with PD-L1 TC more than 25%. So both of them is not included as an option of monotherapy. The first trial to showed an improvement in survival with single immuno in high expressors of PD-L1 was the Keynote 24. It was including patients with PD-L1 expression of more than 50% to be comparing pembrolizumab single agent versus platinum doublet chemotherapy. And after 5 years of follow-up, we have improvement in survival. The median reached to 26 months versus 13 months, and also the overall response rate and progression-free survival was in favor of using pembrolizumab as a single agent. We have a very similar design for the cemiplimab, also patient with PD-L1 more than 50%, cemiplimab versus chemotherapy, and the design is similar and the result also was similar, median overall survival of 26 versus 13, overall response rate improvement and progression-free survival improvement. Actually, this two trial has similar design and include patient with PD-L1 more than 50%. The other two trial, the other trial for Pembro and for Atizo that have the similar design was Keynote 42 and Empower 110. For Keynote 42, it includes patients with TPS score of more than or equal 1%, so it is including patients with positive PD-L1, not the higher expressors only, and the patient were randomized to receive either Pembro, single agent, or chemotherapy, and the primary endpoint show improvement in the overall survival in higher expressors more than 50%. We have a median survival of 20 months versus 12 months. Also, there is survival improvement in the other two subgroups with more than 20% or more than 1%. Also, the progression-free survival for those with PD-L1 expression was in favor of using pembrolizumab. The other trial that had a similar design to the Keynote 42 is the Empower 110, that was including patients also with stage 4 non-small cell lung cancer with a good performance status and with positive PD-L1 more than 1%, and the patient randomized to receive atezolizumab versus chemotherapy as the standard of care at that time. And as in Roche trial, the statistical planning is a hierarchical way. First, if we achieve the first survival in those with high expressors, then we test for the intermediate and for the low, and also the progression-free survival the same. This is the endpoint. This is the baseline characteristics. You can see a homogeneous distribution of both with high expressors and those with intermediate and low expressors of PD-L1. This is the expression in both arms. They are homogeneously distributed, and the overall survival showed improvement with the use of atezolizumab versus chemotherapy, with also a similar figure for the Keynote 42. We have median overall survival of 20 months versus 13.1 months with a hazard ratio of 0.59. And also this improvement of survival in high expressors PD-L1 patients showed this improvement was shown along all of the subgroup of the patients. Also, the other endpoint, the progression-free survival, was in favor of using atezolizumab monotherapy versus chemotherapy, median survival of 8.1 months versus 5 months, with a hazard ratio of 0.63. Also, the overall response rate was in favor of using atezolizumab, 38% versus 28%. So with this is the update. The overall response rate was increased by 20% after more follow-up. We have now 40% versus 28%. And of course, this adverse event occurred with either arm is different. We have more adverse event related to chemotherapy, nausea, vomiting, CBC or neutropenia, thrombocytopenia, and anemia, more related to chemotherapy. And we have on the other side for the immune checkpoints inhibitor, immune-related adverse events in the form of endocrinopathy, pruritus, and hepatitis. So we have now 6 positive trial for monotherapy in the, we have 4 positive trial for single immunotherapy in first-line high expressors patients, either pembrolizumab or atezolizumab. So what about to combine IO plus IO in those with positive PD-L1, high expression of PD-L1 versus IO? Actually, there is no head-to-head randomized phase 3 trial comparing IO single versus IO combined, but we can give a deep look to the IO trial, Checkmate 227. It is a phase 3 trial using nivolumab, ipilimumab versus chemotherapy in those with PD-L1 positive and negative. But unfortunately, the endpoint of this trial was overall survival in PD-L1 positive only, despite the result in negative population, especially in squamous, was significant, but the approval of this combination is only for PD-L1 positive patients. If we look to those with PD-L1 more than 50%, you can see that the hazard ratio is 0.69 for Nivo-Epi versus chemotherapy. It is look that it is similar to some extent to the IO single agents. And if we try to put the result of the monotherapy, mono-IO versus IO-IO, you can see that the hazard ratio for progression-free survival or overall survival is actually similar. So use of IO-IO with more toxicity versus single IO with, of course, less toxicity than dual immuno is better. So the recommendation for IO monotherapy for high expressors is better than the IO-IO. So the second very important question, shall we combine the IO with chemotherapy for the high expressors, or shall we give IO as a single agent for the high PD-L1 expressors? Actually, there is also no head-to-head comparison with a phase 3 trial, but we have this FDA pooled analysis that showed that chemo plus IO in PD-L1 higher patient, more than 50%, has a better progression-free survival, but this improvement in survival was not translated to an overall survival. So if you use monotherapy in high expressors or IO plus chemotherapy, the survival is the same. And this is also trying to look to the hazard ratio of the overall survival and the progression-free survival of the IO single agent and IO chemotherapy. We have IO chemotherapy checkmate 9LA that showed also a comparative hazard ratio of the progression-free survival 0.5 for all, and median overall survival also showed a hazard ratio of 0.6 to 0.7. So it seemed that it is not that much higher. And if we compare with the IO plus chemotherapy trial, Keynote 189 for Pembro plus chemotherapy versus chemotherapy for the non-squamous histology, and Empower 150 for the non-squamous atezolizumab, bevacizumab, carboplatin, and nab-paclitaxel or paclitaxel, and also the Empower 130 for the same population, and Empower Lung 3 cemiplimab plus chemotherapy, you can see that the overall survival hazard ratio is ranged also from 0.6 to 0.7, the same as the IO monotherapy. But also we have a better overall response rate with the chemo plus IO. We reached for in this trial to 60-something%. If we go back, we have a response rate of 40s with the IO. So if we have a patient with a symptomatic disease and high expressor PD-L1 that we need a rapid response, IO plus chemotherapy will be a good option. This is the guidelines. We have all in the guidelines, either adenocarcinoma or non-squamous versus squamous. We have Pembro, atezo as a single agent plus cemiplimab. Actually, cemiplimab is not available in Egypt yet, so we are between pembrolizumab and atezolizumab with the same result. Also, combo is a good option for those who are having a symptomatic disease. So to conclude, for PD-L1 high disease, single agent PD-1 antibodies remain mainstay of treatment. Chemo plus IO increase response, but survival is the same versus single immuno. IO combination versus IO has a similar response and survival to single agent, but not as a phase 3 trial. And finally, atezolizumab monotherapy significantly increased the overall survival, the progression-free survival, and overall response rate and duration of response in those with first-line non-small cell lung cancer with PD-L1 high, more than 50% in the tumor cell or more than 10% in the immune cell. and the safety profile was consistent with the prior observation with the atezolizumab trial. And finally, atezolizumab represents a first-line option for those with high expression of PD-L1 non-small cell lung cancer. Thank you.